I think a lot of times if we hear about the specialty of oncology, we think, man, that's a lot of death and dying and a lot of sick patients and doesn't sound like a great specialty. But in today's video, I have an interview with a PA who gives a little bit different perspective on oncology and really talks about some things that you may not realize or think about that are good points and things that you might really enjoy about the specialty. Of course, every specialty has its downsides, so he talks about some of that too. So if you're interested to see what PAs and NPs are doing in medical oncology and what the specialty is like, then stay tuned. Hi, it's Michelle with the Medicine Couch. Thanks for joining me today. If you haven't yet, please hit that subscribe button down below. And please leave a comment down in the comment section. Let me know what you think about this specialty, this video, or about my channel in general. If there's something that you'd like to see that I haven't covered yet, let me know. All right, now let's go discover the world of medical oncology.
Hi, my name is Sunny Stephen. I've been a physician assistant for over 22 years, and I'm happy to be part of this program to help you learn more about physician assistants in oncology.
What aspect of oncology do you work in?
Outpatient medical oncology. Currently, I'm working in genitourinary oncology, and I also do some gastrointestinal oncology.
And are you in a clinic? Or are you working in a hospital? Or are you in a big cancer center?
So I'm in a setting as part of a large cancer center, a very comprehensive care cancer center, but we're working in an outpatient satellite clinic that primarily does outpatient oncology care, as well as some radiation oncology and some minor surgical procedures.
When you work in oncology, are you handling all of the aspects of oncology, or is oncology itself kind of subdivided further into other subspecialties?
So oncology, as you're probably not familiar with, is very broad in terms of how many different types of subtypes there are and different cancer settings from solid and liquid tumors. So in a large cancer facility, generally people are subspecialized into disease process organ systems. And generally everybody, physician assistants and nurse practitioners, are in their own little niche of subspecialized oncology care in a large cancer facility.
And within that niche, do you have access to like all the different treatments? Like, are you doing medication and radiation and sending people to surgery, or is that even further subspecialized?
Yeah, actually, it's very subspecialized. So we're doing medical oncology. So we're doing the systemic treatments. You have a different areas for radiation treatment group and surgical treatment group. So we're only doing systemic treatments for patients with metastatic cancer or needing what's called neoadjuvant chemotherapy or treatments. So treatments before surgery.
So pretty much dealing with the medical treatments is what your part is. I mean, I'm sure you interact with the other departments because I'm sure people have mixtures of treatments at times.
Absolutely. Cancer care usually has a trimodality setting for various treatments, especially in localized disease. So you closely work with your colleagues in surgical and radiation oncology.
And so how did you end up in oncology? Was this something that you kind of always wanted to do, or kind of what's been your career path since graduating PA school?
So I actually got into HIV/AIDS care for about 8 years, including doing an HIV fellowship. And then after I relocated to a different part of the country, I wasn't able to see a lot of HIV care jobs. And I looked around and I found an oncology opening. And I got into that position in a phase 1 cancer setting. And I started there, and it's been staying in oncology since then. I worked about 4 years in phase 1, and then I switched to inpatient palliative care. And after about 5-6 years there, I found an opening in genitourinary outpatient oncology, and I switched to that. And I've been there for the past 6 years, and I'm really enjoying this field and working in the setting that I'm in currently.
What did you mean when you said phase 1 cancer?
Oh, good question. So a lot of people don't know about phase 1, 2, and 3. Those are basically different settings where drugs are approved. So phase 1 is the early first in human studies where they look at new drugs after they've shown promise in animal studies to see if they work in humans and at what dose they work, what the side effects are. So you work in a variety of oncology tumors, and you give people medicines that we have rationale for using for possibly their cancer. And if they do well in phase 1, it's tolerable, it shows some efficacy, it moves on to the next phase 2 trials.
So was that first job, was it just a regular oncology job, but you guys, the focus of that clinic was trying newer medications, or was it a research specific center you're working in?
No, it's totally patient care. So basically, when you're seeing the patients, on the research group is there, and they actually do all the behind the scenes research and coordination. but you're seeing them in the clinic, you're educating them about potential side effects, you're managing the side effects, you're going to see them in the treatment area if they have any reactions. So really, you're doing medical care with drugs that have not been studied before in outpatient setting.
Yeah, that's interesting. I didn't realize that happened outside of people who are specifically working in clinical research. And so now you're in like GU oncology. Tell us a little bit about your patient population. Do you see the full spectrum of ages?
Primarily see adults, so 18 and over, a wide array of ages, but generally we're looking at patients in the 40s to 70s as your majority of patients, and we're seeing bladder cancer, kidney cancer, prostate cancer, germ cell tumors, and penile tumors.
Okay, so what is kind of your typical day like? Are you just kind of like in an outpatient clinic setting, or do you ever go out to the hospital floor or anything else different?
Yeah, it varies based on location, but typically in our cancer facility, the outpatient, I do only outpatient. So the typical day is really coming to the clinic, and the clinic usually starts at 8:30, and you come in maybe a few minutes before that. You look over your inbox. If you don't have anything urgent, then you start with the first few patients, and you pretty much go in a regular setting of patient by patient. And the volume is definitely not as much as a family medicine clinic. Personally, I may see myself anywhere from 8 to 12 patients on a regular day.
So, as a PA or an NP in the setting that you're working in, you are seeing new patients that come into the practice. They don't have to see the physician first and then be followed up by a PA or NP?
Oh, good questions. We actually do have all the oncology patients seen by an oncologist on the first visit. So I'll see them. I'll do the majority of the work in terms of preparing the patient presentation and the medical history, the past treatment history for their cancer care. And then I would present to the oncologist, and the oncologist would go in and go finalize the treatment plan.
Then I assume that you're doing, follow-ups and everything. Is it the type of situation where you have your own patients, or is it just whoever comes in that clinic that day, whoever is available takes the next patient?
So we kind of alternate with some patients, for instance, come in for treatment clearance. So they're due for chemotherapy or immunotherapy that day. And so the physician feels the person is doing well overall based on labs and previous visits, and they may alternate visits where I might see them one visit and the physician may see them next visit, et cetera. If a patient is coming in for acute issue where they are not feeling well, new fever, et cetera, then both of us may see the patient. But the vast majority of non-new and non-consult patients, one of us will see. And very few of the patients will be seen together. But definitely all new patients and consults will do together.
So you're not ever the one that's coming up with the treatment plan per se. I mean, you have input, I'm sure, but it's the physicians are the ones that are always deciding on what that final treatment is.
Right, absolutely. The oncologist is finally the final decision maker on the treatment plan. We'll have recommendations. We'll sit together and talk. And what do you think is the best thing? What do you think? What would you do? And we decide together. But of course, the final decision on the next chemotherapy or the next immunotherapy or combination treatments would be decided by the physician.
In your experience in the kind of medical oncology world, is that pretty typical of how most places work in oncology?
Correct. Yeah, I think the APP, the nurse practitioner and physician assistant, will be making recommendations on next steps of care based on the discussion with the oncologist who makes the final decision. Of course, the APP also have their own independent clinics in some settings where they do a fast track clinic just for monitoring side effects and also for general follow-up care. They also work in what's called survivorship care, and they'll see patients who've undergone treatments and now are in monitoring or surveillance monitoring phase, where they're looking at general medical issues, any recurrence of disease after a set period of, curative intent. So survivorship clinics are usually run only by the APPs.
And I imagine since those are more of just kind of checking in and see how people are doing, that you'd probably see more of those patients in a day.
I think still survivorship clinics that take about 10 to 15 patients a day. You're also talking about cancer, but also you're talking about their vaccines, their diets, exercise, stressors in life, how they're dealing with the post-therapy side effects. So it can be pretty long visits in some situations.
Do you do any kind of procedures in medical oncology at all?
A very good question. I personally don't do medical procedures, but some people consider advanced care planning and talking about advanced care directives a procedure. And so I've done that quite a few times. Care setting when they're feeling well, that's when you want to talk about things like medical power of attorney and code status and living will. And those conversations can get pretty intense. And we like to think of those as sometimes a procedure almost because you have to prepare for it beforehand. You have to have certain style in the approach, and there should be a certain follow-up of that as well. Some of my colleagues do bone marrow biopsies in the clinic.
Okay.
It's not very commonly done in a large facility because there's actually a special center that just does bone marrows. But in some of the smaller oncology centers, the APP in the clinic may also be doing a lot more bone marrow procedures.
I assume you're ordering infusions at times. Do you guys oversee that, or is that like a whole different center also?
Yeah, in terms of infusion treatments, we actually, most chemotherapies and immunotherapies require dual signature. So we order the infusion and look over the format of the dosing, the medications pre and post, and make sure if everything's appropriate. Then we sign the first signature, and it goes to the physician for a second signature. In some settings, there's also a pharmacist. The pharmacist can also do the first signature, and the physician will do the second signature. And it also applies to a lot of the oral tablets, like medications that are commonly used for chemotherapy in an oral formulation.
But the actual infusions themselves, like where the patients are actually coming and getting the infusions, do you have anything to do with that as far as they're monitoring them, or is that done in a separate infusion center?
Oh, so it's an infusion center nearby where the clinic is. So basically in the same floor sometimes, or but in a different setting, you have the chemotherapy administered by the nurses, and you always have a physician or APP on call available if there's a reaction. So they have their built-in hypersensitivity reaction criteria on how to manage it. But there's also a call made in for one of the providers to come check on the patient if there's a reaction. We also sometimes work late in terms of after 5 o'clock if we need to until the last patient is gone. So we always have a provider on the facility for managing a reaction.
Well, other than that, those evenings where you may have to stay late if you're the provider covering that, in general, is this like a Monday through Friday? And roughly what time do you get there and what time are you actually walking out the door?
Yeah, in general, it kind of varies, but it is a Monday through Friday job. All the clinics are outpatient and it's Monday to Friday setting. But in general, I would say people do about 3 to 4 clinics per week, one day for admin day. And then on those clinic days, you're generally working till about 5:30, finishing up notes or orders. I would say it's very infrequent to be past 6 p.m. And most people start by about 8:30.
So you said you get a whole admin day. So you're actually seeing patients 4 days of the week, and then you get an admin day.
Right. So it's very important for an admin day for preparing for new patients. So you look at the patients for the following week, and you really need to have a good handle on the treatments they've had and their cancer kind of oncology history. So it takes about an hour preparation for each new patient, and sometimes longer based on, if I'm seeing a prostate cancer patient that's been being treated for 10, 15 years, there's a lot to kind of recap on. So admin day is generally used for that, and also for any kind of peer-to-peer that are needed in some situations where you need to call the diagnostic insurance center for getting approval for an imaging or for treatments. And then there's always patient care issues coming up, or refills, or medication or schedule issues that you may need to redirect to somewhere. But there's never a dull moment. Admin days is sometimes even busier than the clinic days.
So in the world of medical oncology or oncology in general, we're going to talk about the things you kind of love about it and the things that are not so great about it. But has there been anything that was surprising to you? Anything that you didn't realize happened, or that was just surprising when you moved into that specialty?
Nothing very surprising except the number of different types of cancers there are and how the various subtypes are so different in terms of management. It surprised me to see how people have such amazing will to fight the disease at very late stages. It really inspires you to kind of commend the spirit and the drive in people who are getting advanced oncology care. Care generally is very similar across different spectrums. You're managing side effects that are very common or sometimes very, very expected in terms of learning about new medications and learning how the changes are happening. In the past 10 years, for instance, we've had a plethora of new drugs and combination therapies for various cancers. Those things are very surprising how quickly things are coming about in the past few years. It's
Yeah.
interesting. It's also a little overwhelming to keep track of what's the next best thing to do, how to sequence therapies, and learning about how to manage the side effects. It's very interesting.
So you might have already given us this answer, but is there anything else that you want to mention? Is that something that you just love about this specialty?
If you ask me what I take away most is the satisfaction you get when patients really defy expectations. They may have gone visit outside somewhere and they were told they have 1 year to live. And now we're seeing them year 4, year 5, and they're so appreciative.
Oh,
And that you really never get tired of hearing that. And when they reach certain milestones, they were able to attend their son's wedding, or they were able to see their grandchild, or they were able to see their grandchild graduate high school. Those kind of things that they never expected when they first got diagnosed, but it's actually happening. That's really satisfying to hear.
so we talked about the things that you really, think are great about oncology and things that people might enjoy in this specialty. What are some of the downsides of the specialty and things that people really need to think about if they're looking at going into oncology?
Great question. And that's definitely, a big barrier for some people is working with cancer patients, that when you're working with metastatic cancer patients, the goal is, of course, life prolongation and not cure. It's not for people who have a hard time dealing with the dying process. So that's the downside, is really seeing the family kind of struggle with this and seeing the patient sometimes deteriorate and transition to hospice, or you get a call one day that so-and-so passed away last week or last night. And that's the hardest part of the oncology field. And it's
Yeah.
not for everybody.
What kind of personalities do you think do well in this field? What personality traits should people have?
And I think it varies. You have a wide array of people. You're not really in a zone by yourself. You really can't do everything by yourself. So I think people that have a drive to learn new things and to be able to handle emotional and stressful situations in a calm and kind of realistic manner, those are kind of key features in working in medical oncology. Attention to detail is very important, of course, which applies to a variety of fields, but sometimes more so because they're getting very toxic therapies.
Yeah, I was just to think that imagine that the drugs that you use, the medications you use, have lots of contraindications, and kidney and liver function has to really be paid attention to closely. So
Yep. So up to date becomes one of your close friends, and the NCCN guidelines and a lot of the electronic resources you utilize very frequently.
So if somebody is watching this and they're a PA or an NP and they're working in some other specialty or in family practice and they're thinking about moving into oncology, how would you advise them ways that they could prepare themselves to work in this specialty?
Yeah, very few people get oncology experience during our training. So if somebody's interested in working in oncology due to maybe some patient experience or family experience, and that's motivating to them, I would recommend reaching out to somebody who's already in oncology already. If they're very interested, I would recommend joining a fellowship. There's oncology fellowships at different institutes, and doing a 1 year fellowship that will give you a broad experience in different specialties. There's also some shadowing and educational mentorship opportunities with facilities and oncology providers, but I would learn about it from a person who's working in the field.
Are there any specific societies or anything that you're aware of that's good in oncology that people can check
Yeah,
out?
the American Society of Clinical Oncology, ASCO, and they have subgroups for APPs, and there's also the American Physician Assistant Oncology group, and there's also American Society of Practitioners in Hematology Oncology. So find your local kind of oncology center or find your own oncology educational facility, and they'll probably give you more resources. But there's a variety of journals that are concentrated on oncology for the APP, advanced practice provider, nurse practitioner.
So let's talk about rotations. If someone's a student and watching this or going to be a student soon and they are pretty interested in oncology, are there any specific rotations that you think that people should try for that would help them the most?
Emergency medicine and internal medicine. I think internal medicine, hospital medicine, those are key in terms of medical management of patients that are very critical issues. I think those would be appropriate for as a very good foundation. But there are quite a few facilities that offer rotations, and it's a matter of reaching out to the facility. I've had a number of students from different parts of the country that have come from their PA program as doing a 6-week rotation or 4-week rotation. and they find it very useful to kind of get their feet wet in oncology.
So those students have kind of reached out in conjunction with their program to the cancer center to see if they could line up a rotation. Is that what you're saying?
Correct, yes. A lot of facilities are offering that now. If you're interested in oncology, it's definitely worth going to a large cancer facility.
And what about like IR, interventional radiology? Do they see a lot of cancer patients, I assume?
Yeah, they're a very specialized field, but they only see cancer patients. But different interventional facilities and different other organizations may have a subcomponent of oncology patients, but it very depends on the facility, of course.
So that leads me to another question to think about. Is this a specialty that you think is good for new grads, or do you think that they really should get a couple years foundation in internal medicine before going to oncology?
I think it can be good for new grads. I think it's a program that has a good orientation schedule and a good peer mentorship program, and very, very prominent opportunities exist for jobs as cancer care is exploding. There's a shortage of oncologists. You don't see too many physician assistants in oncology. It's less than 5% are really in oncology. So there's I'm sure, a big area of growth anticipated for advanced care providers in oncology. I would recommend people coming right out of school and also have some experience in other specialties. That's also fine to transition into oncology.
There's somebody looking at oncology. What do you think is the salary compared to working, say, like in internal medicine? Is it comparable or a little bit higher or lower?
I think oncology care and salaries are comparable to, say, cardiothoracic, dermatology, and plastic surgery, some of the higher paying specialties. So I think it really depends on facility and sometimes bonus structures tied into it. But in terms of purely salary, I really think oncology care is comparable to your higher paid specialties.
Do you ever take call, or patients need after hour care? I know that's different by facility, but are you personally taking call?
Yeah, I'm not taking calls. There are APPs that just work nights and take call, or there's an inpatient, actually, a night team that works on calls for inpatient setting. So it's very, very kind of compartmentalized in terms of function. The physician is always on call, GU or oncology physician available. We're not required to take call or work weekends.
So what about NPs? Or do you, in your experience, is it pretty evenly split with nurse practitioners and PAs in oncology, or does it seem to favor one or the other in your experiences?
Right. My experience, I think they're pretty evenly split. I think you may see more physician assistants in acute care settings. So PAs have more broad kind of training in their field, so they are able to go into some settings where NPs cannot, such as, for instance, first assistant surgery. So in terms of general medical oncology, it's fairly evenly split. I think nurse practitioners and PAs do very essentially same functions as APPs, advanced practice providers, are term used, and on very similar job responsibility.
Quick little point in there, because I know that if there's some nurse practitioners watching, they're probably screaming right now, we can work in the operating room. And of course, they can work in surgery. It's just a little bit difficult path sometimes for them. They may be required to get a first assist credentialing before they can work in surgery. But your point is well taken. It's easier for PAs to move into the surgical realm.
And we have excellent nurse practitioners at our facility, and we work very closely with them. I have seen actually nurse practitioners work more in the survivorship clinics, where they're doing independent survivorship clinics. I've seen more nurse practitioners in that role than PAs. And there may be just more programs available and more people graduating and choosing oncology care.
Yeah. Okay. So any last parting thoughts, anything that I didn't cover that you want to say, or any last pitch about why people should go into this specialty?
I think it's a very innovative and satisfying specialty for the right person. Plethora of jobs available. I think in terms of reimbursement, people can get fairly good salaries in working in oncology. They can have enormous opportunities for growth, and you can also branch off into different non-healthcare jobs as well, in terms of pharmaceuticals or to insurance. There's also an excellent opportunity for lateral movement within oncology. So for instance, if you're working in one specific field and you want to switch to inpatient or want to work with another disease organ subspecialty, that's also an excellent feature of oncology, because there are very similarities in terms of function. And so you can change fields rather readily and learn new disease entities. For instance, if you want to switch from GI cancer to let's say sarcoma or if you want to switch from breast cancer to GU cancer, et cetera. So a lot of people move around fairly frequently. You have a core group of APPs that stay in the same field for 30, 40 years. And then you have a lot of other people that kind of change every 5, 6 years, depending on, what they're interested in. So I think I would recommend somebody consider this as a field in their life career.
But it does give you kind of a refresher to your career to be able to move that way. So that's an interesting point you bring up.
Right. And people can also switch to, for instance, inpatient. There's also opportunities for a lot of inpatient care in oncology. So hospitalist oncology care is growing. There's opportunity for people to work in as a subspecialty in hospital oncology care.
Yeah, and I also imagine that that if you wanted to move into, like you had done earlier, palliative and hospice care, you would probably already have a lot of training that would be useful to move into that specialty as well.
Right, absolutely. In terms of symptom management, a lot of what we do in oncology is, as the APP, is symptom management and addressing things that are very common across a variety of cancer spectrums. So that would be very useful for symptom management centers, especially palliative care, and also different oncology specialties.
So in addition to the moving laterally within oncology or moving to inpatient, versus outpatient, are there other non-clinical roles that you sometimes see PAs and NPs moving from oncology into? Like, does oncology kind of prepare people for some certain roles?
Good question. It depends on how big a facility you work for. There's various opportunities for administrative roles, and I've seen PAs and nurse practitioners go into areas that include being managers or clinic directors, also going into things like health informatics. And to see some people go into actually pharmaceutical industries where they're working as medical science liaisons or insurance field sectors. So I think oncology, because it's very dynamic field, ever changing with different kind of offshoots in different settings, I think it prepare you for various other careers that are apt to hire somebody with oncology experience.
Yeah, I imagine, especially on the pharmaceutical side, that you're using a lot of complex medications and medications people may not be that familiar with. And like you said, the field is always advancing and changing. So I can imagine that pharmaceutical companies would need MSLs who have experience with using these particular medications.
Yes, somebody who has clinical experience in using certain medications in certain oncology fields are more likely to be able to connect with other providers in the educational setting if they need to later on in life. So it's not for everybody. Personally, I see myself staying in patient care, but somebody else may want to approach a different sector within oncology.
A lot of great points there. I didn't even think about half those things you just mentioned. Well, thank you so much, Denise, for your time today and for sharing what it's like to work in medical oncology.
Thank you, Michelle, for having me. I really appreciate the opportunity to share a little bit about medical oncology, and hopefully people can be inspired to look into it further and maybe use that as a career path for themselves. And I'm available for email or questions. If they have other questions for me, be happy to help. But thank you for inviting me, Michelle.
Great. Thank you so much. That was great what Denise had to say about the world of oncology, but I also liked what he had to say about how being in oncology can open up other doors for you and move you into other roles, even some great non-clinical roles. If you don't know what an MSL, a medical science liaison, is or what they really do, or just want to learn some more about them, then you can watch this video here. And I'll also put a link to the playlist of medical specialties if you're still looking for the specialty that is right for you. Thanks for joining me today. Take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.